MRI systems. And there is a paper out that is essentially sort of a summary of several of the major changes that will be incorporated in the guidance document when the guidance document is released all together as one. The elements in the summary of changes will be in the document, but then there will be some other lesser changes in there as well. And then I have my own consulting group, Gilk Radiology Consultants, and most of what I do is related to MRI safety, whether it's products or facilities or practices. In the past few years, I have been honored to give presentations at the Radiological Society of North America, the American Association of Physicists in Medicine, American Healthcare Radiology Administrators, ICRM, International Congress Radiology and Medicine, that was here last year. And then next week I'm going to be at the Global Health Expo, presenting and exhibiting with the radiology planning. So I imagine I may see some of you again next week. So my attachments, beyond what I mentioned there, I am an employee of radiology planning, and through my consulting organization, I do ongoing consulting work with Metrosense. So with respect to the remainder of the morning that we will share together, a few things. If you have questions, don't feel as though you have to wait until we have a question and answer period. If there's something that is sort of tickling you and you need to speak about it, by all means interject, raise your hand, disagree with me if you disagree, ask me a question to clarify if I'm not making myself clear. I can stand up here and I can talk to an empty room, and I'm good at listening to myself speak. But I would much prefer that this be, as to the degree that it's practical, that this is a conversation. And if there are questions or concerns, that you bring those to me as we're going through this material. Anything that you see here is free to share. And I would not only say it's free to share, I would encourage you to take any of this information back to your facilities, share it with your coworkers, your colleagues, and do whatever you can to try and make this information as accessible as possible. A quick summary of what it is that we're going to talk about yet this morning. MRI accidents and injuries and what represent the most frequently occurring sources of injury in the MRI environment. The three forces, also called the three buckets with respect to risk. What they are and where they exist. We'll talk a little bit about MR conditional labeling for implants and devices, how to interpret what MR conditional labeling says, and how to work around what it doesn't say. We'll speak briefly about differences between 1.5 Tesla and 3 Tesla MR systems as it pertains to safety. We'll talk a little bit about sedation and anesthesia, and what some of the risks are associated with altered patients, unconscious patients. Also talk a little bit about some of the burgeoning technologies with MRI and ways in which MRI is leaving the radiology department and distributing in other places within the hospital, and some of the challenges and the risks that presents as MRI wanders a little bit. And then we'll talk through a few scenarios. And I will test you and you will test me in terms of what of this information is practical when it comes to an individual patient care situation. The outline I just gave you, if we were doing an MRI safety course, the outline I just gave you would be 2 to 3 days of material. We're not going to spend 2 to 3 days here, we're going to spend a few hours. And so I'm going to go through this material at a fairly high level, and we won't get too down into the details. And I ask your forgiveness for the fact that we will be skimming over some of that. If you have any questions beyond that, please see me afterwards. I'll be more than happy to answer any questions you have. I will give you my card, my contact information. You can reach out to me at any point in time to do that. MRI safety is, in practice, it's based on some very simple premises, some very basic rules. But to really understand how to implement those rules, it becomes really important to understand, in many cases, the physics behind the reasons we're concerned about that. The biological function that the physics impacts. We'll talk a little bit about that in this presentation. And it's with that foundational knowledge that we can begin to craft specific policies, procedures, practices, trainings that really make meaningful impacts in MRI safety. So, as I said, over the next few hours, you're going to test me and I'm going to test you. And the testing starts right now. So I'm going to present you with a scenario, and later on in the presentation, we will talk through this at length. But just to begin with, if you had a patient who presented for an MR of the knee, and they had a deep brain stimulator, and that deep brain stimulator was MR conditional, and it said, you may perform the study 1.5 Tesla, head only, 0.1 watts per kilogram. Patient presents for a knee study. How many of you would consider performing the study on that patient? How many absolutely would not consider? Okay, I think 90% of you are still asleep or your hands don't work. Let's do this again. Everybody must vote either yes or no. Would you consider this study? Okay. Would you not consider this study? Okay. Roughly evenly divided. Thank you. As I say, I'm not going to go into this right now. We're going to talk through some of that foundational information first, and you will see this again.
The study with 1.5 Tesla, you mean?
With 1.5 Tesla, yes. So, in terms of recorded information, and this is based on data from the United States Food and Drug Administration, the most frequent sources of MRI injury are burns, projectiles, and hearing damage. These are the most frequently occurring injuries. This is a plot. This is based on US data. The red line represents changes in MRI accidents as reported to the FDA using the year 2000 as a baseline. So all we're doing is we're looking at the percentage change based on the year 2000 numbers. I picked 2000 because it's a nice round number. But we look at the percentage change in red of accidents, in blue, the number of MRI procedures. In theory, if MRI is just as safe today as it was in the year 2000, the red line and the blue line should be right on top of each other. There should be no difference in terms of the change in accident rate versus the change in the number of MRI procedures or studies that we do in any given year. Clearly, that's not the case. If you just do a best fit curve or best fit trajectory for these two lines, and in fact we ignore most of the large jump in the middle of the accident rate, or the jump at the accident rate that occurred in the most recent data in 2018, just trying to flatten out those curves and look at straight lines, the accident rate is at its most favorable 2.5 times change in accident rate based on the change in MRI procedure volume. What this means simply is today we hurt more people in MRI than we did 20 years ago. How can that be? We market MRI. We praise MRI as the safe modality because it doesn't use ionizing radiation. But it's not the safe modality in the sense that we can't hurt people, because we are hurting people more frequently now than at any point in MRI's history. We need to recognize that even though we promote MRI as the safe modality because of its absence of ionizing radiation, that doesn't mean that there aren't other unique safety concerns or considerations for MRI that we need to take into account. One very useful piece of information that I hope you're able to download and share with your colleagues is this MRI infographic. This is from the MetroSense website. This is a study of 2 years, in-depth detailed study of 2 years of MRI injury accidents as reported to the US FDA. And we went through and we tested the 3 most frequently occurring forms of MRI equipment-related injury: burns, projectiles, and hearing damage. We tested each one of those events against existing best practice standards to try and see, is there something specific in the ACR guidance document that if the facility had done whatever, fill in the blank, would it have prevented the injury accident that occurred? So we had to look at reports that had enough detail that we could figure out what was the causation, and was there an explicit prevention and an explicit practice that would have interrupted that cause that produced the injury. What we found is, looking at those 3 injury accidents, burns, hearing damage, and projectiles, they constituted 95% of all the injury accidents in the 2 years worth of data. So we discarded the 5% that didn't include. When we looked at the protections, 74% of all of the injury accidents that we identified in here would have been prevented with the handful of existing established best practice preventions. For burns, there are 3 protections that would have stopped 94% of all of the burn incidents that were reported. Those 3 preventions are to pad the patient from the transmitting RF element. For most studies, that's the bore wall, the body coil. There's what's called proximity burns, where the patient's tissues are too close to the transmitting element, and pads are almost 100% effective in terms of preventing that when you place them between the patient and the transmitting RF element. The second most frequent source of burns, RF-related burns, was an electrically conductive material in the bore with the patient. That might have been their clothing. It might have been an EKG lead or a pulse ox lead, or a coil cable for a coil element that was unplugged. It may have been the patient's own clothing. We now have antimicrobial clothing that is either woven with metallic fibers, or the organic fibers are treated with nanoparticles of copper or silver, such that the undershirt that the patient may be wearing, if it's treated with this antimicrobial compound, the undershirt, even though it looks like a cotton undershirt, may be capable of transmitting electrical current, which means it can act as an antenna, which means when we bombard it with radio frequency energy, there is the potential that it may heat up. An undershirt, or other elements of clothing. The third most frequent source of burns is skin-to-skin contact. These typically manifest in large caliber body loops. So if we were doing a T-spine study, for example, and I was laying in the bore and I had, my thumb touching exposed skin on my thigh, and we've created a large loop. We'll talk a little bit about this when we get to the physics portion of radio frequency, but when we induce radio frequency energies, when we transmit radio frequency energies into the patient, it induces currents in the patient's own tissues. Not enough that we're shocking the patient. That's time varying gradients, and that's direct neuromuscular stimulation. We'll talk about that as well. But the radio frequency transmission induces electrical currents in the patient's tissue. They're benign. They don't hurt. The patient is completely unaware of them. The degree of current that those radio frequency transmissions are capable of producing is in part a function of how large of a diameter, how big of a racetrack of a circuit do we provide that electrical current. The bigger the potential pathway, the more current can build during the radio frequency portion of the exam. When we take my scenario of my thumb touching my thigh, for example, we create a very large loop, which means we can induce a significant amount of current. The challenge comes when we have small point of contact, the 1 square centimeter of the tip of my thumb against a corresponding 1 square centimeter of the surface of my thigh. Through most of that circuit, the electrical energy is passing through blood and blood-rich tissues like muscle. And electrical current flows through water fairly readily. Electrical current does not flow readily through skin or fat, not compared to blood and muscle tissue anyway. So what we do is we wind up creating point of resistance to that electrical flow at the tissues where we have a small point of contact. We narrow the roadway. We go from a 12-lane freeway, interstate, down to a single-lane unpaved road. We narrow it down to a narrow point of contact, and then we create all of this electrical resistance. And all of that electricity trying to force its way through converts the heat and can produce burns. The interesting thing is that if we have an electrical conductor on the surface of the patient's skin that heats up, the patient may feel it, and they may alert the radiographer. They may squeeze the alert ball and say, I'm too hot, something is burning, and let's fix this. If that same electrical conductor is inside the patient, meaning not at the skin surface where we have temperature and pain sensors, we can burn the patient with an electrical conductor that is inside them, and they will have no idea. The other two, the proximity and the large caliber body loop, the theory for both of those is that the burns that those produce actually manifest in the fatty tissue where we don't have temperature or pain sensors, meaning you can effectively be burning your patient, cooking your patient, and they have no idea that it's happening. So the notion that we give the patient the squeeze ball and therefore we will prevent all burn injuries, because if the patient's being burned, surely they know it and they will let us know. For the majority of radio frequency related burn accidents, that's simply not the case. So we have to take the preventative steps with padding. We do these 3 steps. We would prevent 94% of the reported burn injury cases in the FDA database for the 2 years that we studied. Hearing damage, we don't do nearly as well with. 89%, is that right? Yes, 89% of the reported hearing damage cases, the patient was at least offered hearing protection, Either they declined to use it, or they used it, but they just didn't put it in correctly, didn't get the maximum effect out of those compressible foam earplugs. It's really easy to put a foam earplug in your ear. It's actually a little bit difficult to get it in correctly and in so that it seats appropriately. My left ear must have very strange outer ear canal anatomy. If I have those compressible plugs and I put them in simultaneously on both sides, 95% of the time the one on the right side seats first try without a problem. Invariably, it takes me 3 to 5 attempts to get it to seat correctly on my left ear. I don't know why, but they will not seat very effectively. And I know what the difference is. I know how to tell whether it's seated correctly or not. Most of our patients have no clue. So simply providing hearing protection only stops about 11% of the reported injuries. 11% of the hearing damage, the reported hearing damage cases are from patients who didn't get hearing protection at all, weren't even offered it. The other 89%, they were at least offered or given and they just didn't use it effectively. So I would like to add these two as sort of standards for us. One of them is we need to verify fit and function. We need to make sure that after we give our patients hearing protection, that it's actually doing what we think it should be doing. There are a couple of ways that we can do this. One of them is if you have the radio playing, you have a music source or something, you can ask the patient to cup their hands and place them over their ears as if they were trying to protect against a loud noise. If they can tell a difference in the sound level from the radio, from the music that's playing, if there's a difference when they do this as opposed to when they do this, then the hearing protection is not in effectively. If this makes a difference, the only way that that can make a difference is if the compressible foam plugs are not in correctly. Another technique that has been suggested to me is that you stand behind the patient and you whisper something to them. And you ask them to turn around, or you ask them to verify their name, or something that would be fairly straightforward and they would respond to. You should do it in a low voice. And if they fail to respond, it's a decent indication that they have the hearing protection incorrectly. If you whisper to them from behind them to turn around and they do, that's a good indication that they don't have the hearing protection incorrectly. Third recommendation is that we provide an alternative means of hearing protection. If all you have are the compressible foam plugs, if you have a patient who has a phobia of putting something in their ear, or maybe they're like me and they just have some strange ear canal anatomy and it just won't work for that patient, what's your second option? A lot of facilities don't have a second option, and this is a failing on us. Providing hearing protection alone only prevents 11% of the reported injuries. I bet if we did the next two items, item 2, item 3, we could really make a very significant impact in terms of reducing the rates of auditory damage. The third of the three most frequent injury accidents is related to projectiles. And the three things that, the three preventions that would have stopped 69% of the reported injuries in the 2 years that we studied, the use of the ACR 4-zone principle. For those of you who may not be familiar with the ACR 4-zone, essentially it means the closer we get to the magnet, to the MRI, or to the room that has the MRI in it, the more we're going to make sure that that individual is screened or trained, or we are going to lock them out. Unless they're screened, they're trained, they're supervised. So it's a bullseye. As you move closer towards that center ring, towards zone 4, where the MRI is, you have to go through increasing levels of screening, security, and supervision. And that's the basic premise of the ACR4 zone. The use of ferromagnetic detection systems. Projectile objects, by definition, essentially have to be ferromagnetic. So if we use a ferromagnetic detection system to identify them before they go in the room, we can dramatically reduce the rates of those types of accidents. And the third recommendation here is to plainly, conspicuously label items that live in the MRI suite that have a likelihood of being brought into the room. There are some facilities who feel as though they almost have to label every paperclip that lives in zone 3. I think that that's a bit extreme. I think we should focus our attention on patient care equipment that may come and go out of the room. So that may mean anesthesia machines, or ventilators, or medication pumps, or wheelchairs, or trolleys. Anything that is inside the controlled access portion of the MRI environment, that there is the potential that may get brought into the MRI scanner room, those items should be very conspicuously identified so that it doesn't take special training or somebody who was here when we purchased this and the in-service was given 3 years ago for this new ventilator, that all the person needs to be able to do is go up to the object and identify whether it's labeled as MR conditional, MR safe, MR unsafe, and be able to readily identify the safety characteristics of that product or that device. So there's a double asterisk by the 69% accident reduction. That double asterisk is because the 31% of projectile accidents that were reported in these 2 years came from manufacturer personnel or third-party service personnel, third-party service companies that were there to take care of your MRI scanner. If we only look at clinical situations, your doctors, your radiographers, your patients, and we exclude the GEs, the Siemens, the Philips, we exclude them from consideration, this number goes to 100%. In the 2 years that we studied, these 3 protections would have stopped 100% of the projectile-related injury accidents that occurred. This is an example of the Metrosense ferromagnetic detection system, the type that's mounted outside the doorway. Here's a different view, a different installation. In addition to the ones at the doorway, there's what's called a screener system that is typically installed where you prepare the patients in your zone 2 environment. My recommendation is that the screener type of systems are close to where you have your changing rooms and your patient lockers, so that when you discover something, you don't have to back the patient all the way up from the magnet room back to wherever the changing and screening areas are. That this just is a part of that process. So anything you do discover, you're just right there, you put their belongings in the patient locker. I can't tell you how many times patients are interested in doing a Facebook post about their MRI scan or something like that, and are desperate to sneak their smartphone into the room with them. Obviously that's not good for anybody. So those preventions, the 3 protections for radio frequency burns, the 1 protection for hearing that came from the ACR guidance document. We didn't measure the 2 that I'm recommending in addition to that. And then the 3 protections for projectile-related The three that I identified for radio frequency burns, the three that I identified for projectiles, and the one for hearing damage, those are all existing best practice statements from the ACR guidance document. Those taken together would have stopped 74% of the injury accidents. And if we exclude the service personnel from that, that 74% jumps to 80% in terms of the percentage of injury reduction that we can do. 80% injury reduction is pretty substantial improvement. And that's just with 3 sources of injury and 3 protections for each of them. And I know that we can get to this level. The thing that consumes radiographers' time, the greatest quantity of radiographers' time relative to MRI safety, isn't even on the list of the top 3 sources of injury: implants and devices. Implants and devices do produce patient injury, and when they produce patient injury, they can produce catastrophic injury. This is a translation from a Spanish news publication of a woman who went for an MR study. She had an implanted pain pump, and following the MR study, the pain pump malfunctioned and dumped the entire load of narcotic into the patient, and she died of the overdose because of the malfunction of the pain pump resulting from exposure to the MR study. The details of that are kind of scant. These types of accidents don't, in numbers, don't even crack into the top 3 at present. But as we have a greater number of implants and devices, greater varieties, more common in our patients, the likelihood that implant and device related injuries and accidents will go up, I think is really sort of a foregone conclusion. But that's another item that we need to be concerned about. We're going to talk a bit about how to identify the risks to implants and devices and how to mitigate them. And we're going to do this by discussing the 3 separate electromagnetic forces that we subject patients to during an MR exam. We subject them to the static magnetic field, the always on, the 1.5, the 3T. We subject them to time varying gradients. And we subject them to radio frequency energy during their studies. I thought I may have gone past a slide. For the static magnetic field, static magnetic field is the portion of this, one of the 3 that is responsible for translation, missile effect, things going flying. That is, in most objects, just a direct product of the properties of whatever that object is, whatever the properties are, and that the object's interaction with the magnetic spatial gradient. The 720 Gauss per centimeter, 4.2 Tesla per meter. Those are measures of spatial gradient, and that is the factor that is principally responsible for the translation or the missile effect, an object that goes flying. Rotation, the tendency of an object to want to twist and align with the magnetic field, like a compass needle, right? If you hold a compass, the needle on the compass will twist to point north. Same thing inside an MRI. If you have something that is linear, whether it's inside the patient or outside the patient, it's going to want to twist to align with the north pole of the MRI. For Bohr format magnets, The north-south is always the z-axis, the direction of the bore. There are also lenses forces. Lenses forces are forces that are only produced through motion. So if this is the opening, the bore of the MR scanner, and I come with an electrically conductive item, doesn't have to be ferromagnetic. Static magnetic field forces, torque and translation only work on ferromagnetic objects. Lenses forces work on anything that is electrically conductive. I come with a large electrically conductive material, an aluminum pie pan, and I start moving towards the opening of the MRI, where the spatial gradient is the greatest at the mouth, the front end and the back end. As I am moving towards this, I'm moving an electrically conductive material through a magnetic field. Faraday's law of induction, when you move an electrical conductor with a material with low resistance to the flow of electrons, when I move it through a magnetic field, that action induces a voltage in that material. Like what we talked about, the large caliber body loop and the radio frequency inducing a voltage, the bigger the circuit, the bigger the pathway, the greater the induced voltage. Lenses forces do something very interesting. Whereas the translational force draws a ferromagnetic object to the magnet, lenses forces do the exact opposite. They retard the advancement of an object that is electrically conductive. My friend, my mentor, Dr. Emmanuel Canal, tells this great story of when he has resonance. I don't know if he still does this or not, but when he has resonance, very beginning with the radiology resonancy, he runs all of them through a drill to a practice session to try and do a code response to a patient who stops breathing in the MRI. And he gives them an aluminum, an MR conditional oxygen cylinder, and he says, okay, I'm going to time you. I want you to get this with a hose and nasal cannula attached. I want you to get this onto the patient as quickly as you can. And he says, go. And the residents, they grab this oxygen cylinder, they run into the room, and they run up to the MRI, and invariably, as they get close to the MRI, and the lens effect acts on this large aluminum cylinder, it stops the advancement of the cylinder. It doesn't stop the legs moving for the person who's carrying it. So it stops, and the person goes like this and gets knocked over because the air cylinder freezes in midair as they're advancing towards it. Dr. Canal has this great anecdote. He says, every single time he's ever done this, the male residents try and run faster or harder, push more to get that oxygen cylinder in. He says the female residents, as soon as they see what happens with the male residents, they run up to the place where they see the tank stop moving, and then they stop. And then they do this. And they walk just right up to the magnet. Lens effects, lens forces, are a product of the spatial gradient, the rate of change in the magnetic field, plus or times the size of the electrically conductive pathway that the object provides, times the rate of motion. If you bring any one of those three things down to zero or close to zero, so if you're walking slowly with this object instead of running with it, you can have an incredibly steep spatial gradient. You can have a very large electrically conductive pathway. But if you're moving it slowly, big times almost nothing is almost nothing. So lens forces are interesting. They rarely, that we know of, produce an injury. There is a reported accident involving a nurse in a hospital in Germany who had a stapes implant that was made from titanium, and she was running towards the magnet, patient who was in distress, and as she got very close to the magnet, she describes it as feeling like a ping in her inner ear, and the stapes became dislodged, and she had to have it surgically corrected. Lens effects are not terribly common, both because we usually aren't moving very large objects close to the magnet, and when we are, we're generally moving fairly slowly. It's rare that we have this magical combination of the three factors: a large electrically conductive object moving in the steepest portion of the spatial gradient and doing so very rapidly. So lens effects are interesting, not very frequently a safety issue. It is interesting, however, that sometimes we can confuse a lens effect with a safety issue. If you have a patient who, for example, has an implanted medication pump, those are sometimes decent sized electrically conductive pathways, and if the patient is moving rapidly as they're getting positioned up on the table or something like that, they may feel what to them feels like a tug, feels like something pulling at the implanted pump. When in fact it's not pulling at the pump. What it's doing is it's actually saying slow down, and it's trying to retard the motion of the pump. That can lead us to some false assumptions and some mistaken conclusions. That just because the patient feels it does not mean that it's ferromagnetic and the magnet is trying to rip it out of their abdomen. It may be the exact opposite. It may be just the lens effect that's saying slow down a little bit. If you only just moved a little bit slower, this would not be an issue. Take it easy. Bioeffects of the static magnetic field. To the best of our knowledge, there are no persistent physiologic effects of being exposed to a static magnetic field. We do know that there are a number of temporal effects. If you're exposed to a high enough magnetic field spatial gradient, you may experience magnetophosphenes. If you ever close your eye and apply pressure on the outside of your eyelid, put pressure on your eyeball, you will see spots. The pressure induces elements of the optic nerve to fire. And so you get visual stimulus without seeing anything. You can do the same thing through exposure to a spatial gradient of a magnetic field, magnetophosphenes. You can essentially trigger the optic nerve, and with your eyes wide open, you can begin to see, sparkles or colored spots. This is not terribly common for people to experience at the field strengths we typically work at. 1.5 and 3, it's kind of a rarity, but it will happen. We do know that the fluid in our semicircular canals is electrically charged. An electrically charged fluid, as it moves through a magnetic field, experiences lenses forces. And so the lenses forces retard the motion of the fluid in our semicircular canals. What this means is, if we rotate our head about any of the axes quickly, when we are in the steep parts of the spatial gradient, the fluid in the semicircular canals, which normally moves at essentially the same rate that our head does, will move slower. And so there will be this lag between what our brain perceives our spatial position is and what our actual spatial position is. And this can produce vertigo and nausea. The difference between what our brain perceives the position is versus what our eyes are telling it is. So the retarded motion of the fluid in the semicircular canals will produce vertigo. Again, temporal effects. As soon as we remove the individual from the magnetic field, these things clear up. Some people may have sort of a lingering feeling from vertigo or nausea. Just because you take them out of the room doesn't mean, you know, they're instantaneously better. But these effects are presumed to be pretty benign and short-lived. Magneto hydrodynamic effect. Again, this is a lens effect type of product. Where you have a charged particle fluid, and blood is a charged particle fluid, where it flows in the direction of the bore of the magnet. So if you have a patient laying down, the aortic arch is where you have the highest volume of flow of a charged particle fluid that's going in the direction of the magnetic field. What happens with a lens effect when we have that large object, we're going towards the magnetic field, it retards the motion, right? Magneto hydrodynamic effect does the same thing to blood in the aortic arch, primarily. And it actually retards the motion of blood flow. The effect is very modest. It results in a couple of millimeters of blood pressure increase necessary to essentially force past that. Clinically, I don't know that it really makes a difference in terms of the care of any patient. Like I say, it's an incredibly modest effect at the field strengths we normally work at. If you get a 7T, this really hasn't been looked at very closely in 7T, and so maybe it becomes a concern. Maybe our end-stage heart failure patients, maybe we want to be concerned about them at 7T. I don't think that it is significant enough at lower field strengths per my conversations with Dr. Canal. Flow potential. If you are doing cardiac gating on a patient, or you're just trying to get an EKG, you're trying to monitor cardiac rhythm, a material flowing through a magnetic field, Faraday's law of induction, an object that moves through a magnetic field creates a current. An EKG is a current detector, a voltage detector. You're looking for the voltage that is produced when the heart is triggered to beat. That's what an EKG is measuring, is it's measuring the quantity of electrical voltage. Except now the flow of blood is producing a voltage because it's moving through, it's a charged particle moving through a magnetic field. It creates an induced voltage. So what this can look like on an EKG is an elevated ST segment. Essentially, when you look at an EKG and you see the QRS spike, right? What you are seeing is the nerves telling the muscles contract. QRS, the R spike. You're looking at the moment when you're getting maximum nervous indication to the muscle to fire. But the muscle doesn't do that instantaneously. There is a short lag period. It tells the muscle to go, and then the muscle goes, okay guys, let's go all together now. And you get a contraction. So there is an electrical indication of a contraction that precedes the actual contraction of the heart. Electrical systole, physical systole. And physical systole is just a moment behind. Why you see the manifestation of this in the ST segment, so we have QRS, and then we have a big blob in the ST segment, is because that is where the blood is flowing, and a moving charged particle in a magnetic field induces a voltage. And so what we're actually seeing in these elevated ST segments in an MR is we're measuring the electrical current that's generated by the flowing blood as it is ejected from the heart. And the greatest place where you're going to see that is if you have an EKG lead that's picking up the aorta, the aortic arch. If you're doing cardiac gating, if this effect is pronounced, the scanner may perceive this elevated ST segment as another QRS spike. And it may count 2 heartbeats for every one that the patient is actually having. Also, an elevated ST segment to a cardiologist can look like any number of really bad things happening to that patient. So if you have a cardiologist or a cardiac nurse monitoring this who is not familiar with how this affects us biologically, they may freak out. And they may think that this patient is in distress, when in fact, if we just relocated the ECG patch, or unplugged the one that's kind of pointing at the aortic arch, the effects of the elevated ST segment and the effects that that may have on cardiac gating may disappear entirely. So these are the biological effects. And again, we think that, to the best of our knowledge, these are all temporal, these are all benign. This is one of the reasons we call MRI the safe modality, is because we don't think any of this has any lasting impact on any of our patients, or any of our radiographers for that matter. We describe, in terms of the units of measurement, the static field in terms of Tesla or millitesla or Gauss. We define the magnetic spatial gradient in terms of the field strength change over some unit distance. The European standard for that is Tesla per meter. The US standard for that is Gauss per centimeter. Those values change over such small distances that I'm partial to Gauss per centimeter, because nobody in their right mind would ever measure a spatial gradient across a meter of space when we're talking about an implanted device that's 5 centimeters in size. Having it averaged over a meter just is not very helpful. Having it averaged over a unit of space that actually pertains to the implants and devices that we're looking at, in my opinion, I think that that's just a smarter way to do it. So this is what the static magnetic field from a safety standpoint is really known for. This is an excerpt from a GE safety video that's probably 20, 25 years old at this point. It's a wrench that weighs maybe a kilogram. This is an old 1.5 Tesla GE magnet. I think this is one of their S2 or S3 magnet systems that had very poor active shielding. As active shielding has gotten better on these magnets, what that means is that the spatial gradient, the part that really drives translational force, gets higher and higher and higher, which means the speed with which something will fly keeps getting higher and higher. It also means that there is less feedback time. It used to be, when they made that video, that if the magnet was over that direction and I had something ferromagnetic in my hand, as I started walking towards that magnet, I would feel nothing. I would feel a little bit of pull. Oh, now it's really pulling. Oh, now I have to hold onto it with 2 hands. Today, because active shielding in MRI scanners is so much better than it used to be, what it means today with that same object is, as I walk towards the magnet, I feel nothing, I feel nothing, I feel nothing. Whoosh, it's gone. Without any meaningful period of feedback to tell me that something is changing. Active shielding compresses the magnetic field, which means there's an alarmingly higher spatial gradient, a much steeper spatial gradient. This can lull us into a false sense of security if we step through the doorway into the MRI scanner room and we don't feel anything. People who aren't familiar with this environment may make the mistaken impression that, well, the magnet must be off, because if it was on, I would feel something pulling. The difference in distance between feeling nothing and having an object ripped from your grasp today is literally a question of centimeters. It goes from nothing to overpowering in, as I say, a matter of centimeters today. Does anybody have any questions about static magnetic field related issues? Either I'm answering every question you could ever imagine, or I've already put you to sleep. Then let's move on to time-varying gradients. The 3 elements for time-varying gradients: direct neuromuscular stimulation, the Lorentz effect, which is distinct from the lens effect. The Lorentz effect is the sound that's created when the gradients are running, and the potential for false feedback. Again, as with the static field, the time-varying field, we believe that the bioeffects are all temporal. There's nothing persistent that we know of that is negatively affecting the patient. What may happen in a short term is we may produce in that patient direct neuromuscular stimulation, and we know that we create noise as a result of the time-varying gradients that may be, at a minimum, uncomfortable. At worst, it may produce hearing damage in that patient. Whoops. So the units of measurement. Gradients are very tricky because we use the same term to really mean 3 separate things. There is the gradient slope, the rate at which the gradient changes as we move away from isocenter in any direction. And that's probably the most frequently reported unit for the gradient. Tesla per meter, millitesla per meter, essentially defining how much does the static field change as we move away from isocenter. Gradient amplitude is the second most common way that I think that this is reported, and that's at the furthest point, what is the maximum change in the static field? And then the third element, and this is really, quite honestly, this is the only one we care about, is the slew rate. This is the only one we care about in terms of direct neuromuscular stimulation, and also the loudness that's created during the gradient portion of this. What we care about is what is the maximum change in amplitude over distance over time. The slew rate, the combination of the maximum, the degree of amplitude change over a shorter and shorter duration. That's what triggers neuromuscular stimulation. There is a term, rheobase, and rheobase is how much power, how much stimulation do we have to pump into a nerve to get it to fire? Externally applied energy. How much externally applied energy do we have to pump into a nerve? If we can pump that energy in over a shorter period of time, we get it to fire more easily. If we pump a greater magnitude of energy in, we get it to fire more easily. As you increase either the magnitude of time or you decrease the time during which we transmit that, we get to whatever that maximum is, the combination of the amplitude and the shortness produce neuromuscular stimulation. We can do the exact same amplitude, but if we apply it over a much longer time, we can reduce neuromuscular stimulation. So it's the combination of rate of change and the duration over which that rate of change is applied. That's slew rate. Because this is poorly understood by the implant device manufacturers, most of the time when you see a gradient condition on an MR conditional label, you'll see this piece. What I think we really should be moving towards as an industry is we should be standardizing on gradient slew rate as sort of our choice. This is what it produces.
I have a question.
Yes,
What's the maximum slew rate for the pediatric as a segment?
for pediatrics,
Yeah.
that is a clinical question that I'm going to give you my best shot at, but I'm not a clinician, so please take this with a fairly significant caveat. I am not aware that the rheobase, that triggering threshold for neuromuscular stimulation changes with age. And so, as I stand here today, I would say I'm not aware of anything that would indicate that there should be a decreased threshold for pediatric patients as opposed to adult patients with respect to gradients and neuromuscular stimulation. Pediatric patients have an advantage over us adults by virtue of the fact that they are smaller. The gradient amplitudes, and we'll discuss this more here in just a minute, are at their greatest near the periphery of the bore. At the center, where ironically, where the anatomy that you're trying to image, the gradients are close to their minimum. And it's the peripheral tissues where that experience the greatest gradient amplitude shifts. And so it's in those tissues where peripheral nerve stimulation is most likely. So in a pediatric patient, at least radially, they're less likely to be near the walls of the bore, so they're less likely to have tissues in the area where the amplitudes, the slews, are the greatest. Now, superior and inferior, if you're doing their head, they may feel a tickling sensation in their abdomen or something like that. I can't tell you, I don't know, and I've never heard anybody express to me that a concern with pediatric patients in particular being more susceptible to peripheral nerve stimulation.
As you know now, all the vehicles are providing very high speed storage or high gradient strength. And there is two kinds of definition of the gradients. The actual gradients and the maximum, which is two gradients put together.
Right.
Number one. Number two, the slew rate, you know that how the speed of gradients switch on and off. This is what will affect the infant and potentially as you know, the slew rate, it's the speed of the gradient to be in the top of the high gradient amplitude. when we say it's 200 slew rate or 150 or whatever, that's mean the switch on and off. This is will affect biologically to the patients. And so that I'm asking, as your experience, is there any conditions or any precautions we have to understand and make careful about the infant or pediatric to be an MRI? Sometimes the people, they said 3 Tesla, it's not for pediatric. Sometimes they said it's for the pediatric. And 1.5, you know, we have different gradient strength now, not like before. We have 3 or 4 gradients type. If you have to, the maximum one is 48 by 200 slew rate. Still, we are concerning about the slew rate and biological effect with the nerve stimulation for the pediatric, especially for the pediatric, especially for the infant. You know, but there is no precautions as your experience for this.
So all I can tell you is that the IEC, the International Electrotechnical Commission, the body that sets the safety standards for the MRI machine itself. I think many of us are familiar with the idea of normal mode, first level mode, and second level controlled mode for radio frequency energy. That's where we tend to use those terms most frequently. The terms also apply in gradients, that there's a normal mode gradient, a first level, and a second level. Normal mode gradients, and I'm going to see if I can summon this from memory correctly. Normal mode gradients is 80%, the maximum slew, it should be such that there's only 80% chance that a patient may perceive at the highest setting, may perceive peripheral nerve stimulation. At first level mode, that's 100%. I think I'm messing this up somehow. Regardless, even if I'm giving you sort of the wrong milestones in here, the IEC has not, to the best of my knowledge, ever defined a separate standard for peripheral nerve stimulation and slew thresholds for pediatric patients than they have for adult patients. They have defined different standards for other elements as it applies to pediatric patients. So using the IEC standards as my point of reference, and not having read anything about a greater pediatric sensitivity to neuromuscular stimulation, the best answer that I can give you right now is I don't think that there's a clinical indication that pediatric patients are somehow at greater risk of the accelerated slew rates. You made the statement about the scanners and systems today accelerating gradients. Every single technological change that I can think of in magnets, except for one, every single technological change is increasing the power that we are depositing in our patients. Greater slew rates, steeper gradient curves, stronger magnetic fields, more powerful active shielding, turbo spin, fast spin, echo. That we have the capability of injecting greater radio frequency power into the patients over a shorter duration of time. The one thing that I think magnet technology is doing that is making things safer, that is reducing the risk, are the new silent scan protocols. And again, those are only for certain sequences and only on certain systems. But technologically, everything except for the quiet scan or silent scan, all of the major technological leaps for magnet technology in the last 10, 15 years have come with additional safety consequences. For this one particular thing with gradients in pediatric patients, I'm not aware of that having a specific risk attached to it. But I think that's a really interesting question. Thank you for asking. I want to touch on the false feedback, and we're going to go through radio frequency energy quickly, and then we're going to take a brief break. So time-varying gradients are pulses of magnetic energy in the tens to hundreds of thousands of times per second. A pacemaker serves two functions. Pacemaker, its first job is to monitor cardiac rhythm, and it does it like an EKG does. It looks for the electrical stimulation that the heart produces to trigger contraction, to trigger systole. If the pacemaker detects that that rhythm is out of range, based on a specific programmed range for that patient, then the pacemaker algorithms kick in and it does something to activate and correct that cardiac rhythm. Time-varying gradients produce electromagnetic fields at rhythms. There is the potential that a pacemaker or another biostimulation device that actively monitors based on electrical signals, that a pacemaker or other device may perceive the time-varying gradients as a seriously out-of-range biological function. If the pacemaker all of a sudden thinks that your gradient, which is firing at 200 times per second, is your heartbeat, the pacemaker may fire and try and recapture that rhythm. Pacemaker will try and fire at whatever the aberrant rhythm is, and then slow it back down or speed it up to where it's programmed to leave that patient. If it thinks that the heart is beating, many times per second, it will fire at many times per second to try and capture that heart rhythm and bring it back down. So it'll start firing at the rate that it perceives the heart is beating, and gradually it'll slow it back down to where it's supposed to be. If it's perceiving the time-varying gradients as cardiac rhythm, and it starts firing in response to the time-varying gradients, it may take a situation where there is no problem and it may create a problem. So false feedback of gradients, rhythmic gradients, producing an erroneous assumption on the part of one of these devices is a real potential. The pacemakers of today, and certainly the MR conditional ones, are much better about this. There are some of the ones from Boston Scientific, I believe, that now have active perception of magnetic field, that they automatically go into like an MRI mode when they're exposed to a static magnetic field, and will disregard external signals like time-varying gradients. So some of this depends an awful lot on the device associated with it. So I will go quickly through radio frequency and then we'll take a break. Oops, let me jump back.
I have a question.
Yes.
Regarding pacemaker, there is specific parameters for, in the MRI machine, parameters to be more safe.
Yeah, so related to pacemakers, are you talking about MR conditional ones or traditional non-conditional ones?
No, conditional.
Non-conditional ones? There are some general statements that can be made. I would defer to, there's a wonderful publication from the Heart Rhythm Society, HRS, that has an extensive publication about doing MR on patients with non-conditional pacemakers. For a number of those patients, we can follow the protocols that we would for an MR conditional pacemaker, with the monitoring and the supervision and device check. And those patients appear to have similar outcomes to many of the MR conditional ones. It's not true for all patients, and it's not true for all devices. That's a more complicated question to answer than we have time for right now, but I would direct you to the publication from the Heart Rhythm Society for that, for a much more in-depth response to that. While it is possible to produce some warming from time-varying gradients, the risk of warming or heating associated with time-varying gradients is actually pretty tiny. If we're talking about heating, 99% of the time we're talking about radio frequency. And this heating can be produced in two ways: diffuse warming or focal heating or burns. As with both static field and time-varying gradients, to the best of our knowledge, radio frequency bioeffects are fairly benign. There are some people who contend otherwise. There are not large-scale reproducible studies that indicate that there are biological, long-standing or long-term biological effects from radio frequency exposure. But this is not as settled as static field or time varying. Units of measurement. We measure radio frequency energy primarily in two different ways. How much radio frequency energy goes into the patient versus how much the machine has transmitted. Specific absorption rate is how quickly we are pumping radio frequency energy into the patient. This is an estimated value. This varies from manufacturer to manufacturer. It varies from machine to machine. It varies on the same machine before and after you have a software upgrade. The manufacturers are constantly revising the algorithm that tells you how much SAR it believes the patient is receiving. SAR is an estimated value. It is not a standardized algorithm, which means running the exact same study on the exact same patient on a GE system may tell you that that study produces 2.2 watts per kilogram. Running the same study on a Siemens may tell you that that study produces a SAR of 3.0. There can be some fairly significant discrepancies between and among the different manufacturers for the exact same study, because it is all estimated based on algorithms. That's SAR. Specific energy dose or specific absorbed energy, SED or SAE, is how much radio frequency energy have we input into that patient over the duration of the entire study. The first one, SAR, is how quickly are we putting it into you right now? And if we stop the study, if we stop the exam, then SAR at that moment is 0. SED is how much have we put into you altogether, cumulatively, over this. Some of your systems probably pop up warnings or alerts saying you have, over the course of this study, you have, given this patient 6 kilojoules per kilogram of SAR, or of RF energy. Some of your systems may have lockouts. There was, for a period of about 2 years, a requirement that manufacturers were supposed to limit the total amount of RF energy to 14.4 kilojoules per kilogram for a patient. And there are systems out there still today that if you are doing a total spine on your patient, you may get halfway through the lumbar and it may lock you out and say, I'm sorry, you can't continue. that lockout requirement, that hardware requirement, went away a couple of years ago. But the system software from that era may still have the lockout built into it. It is now, it's now up to the individual MR manufacturer to decide if and when they want to have a lockout. So this is our estimated transmitted power, either the rate at which we're transmitting it, total accumulated transmission. That's how much we think has gone into the body of the patient. We're now seeing a switch to transmitted power, B1 plus RMS. This is a measure of how much energy comes out of the transmit coil. The reason that we're moving towards that is the presumptions about how much power is being deposited in the body of the patient are all based on the idea of what the electrical conductivity of a patient's tissues are. When we have an implant or device, we have a titanium hip replacement. We have a Harrington rod. When we have electrically conductive metal material in the patient along with their regular tissues, these algorithms go out the window. The accuracy of the algorithms go out the window, because now we're not only transmitting power into human tissues, but we're also transmitting it into more electrically conductive material, metals, that have totally different absorption and transmission characteristics than human tissue. Because that's not factored into the SAR calculations, SAR values in patients who have metal implants are less useful than they are in patients who don't have implants. And I've already told you that they vary tremendously just between and among systems. For that reason, we're beginning to see more and more MR systems and implants and devices that instead of saying a specific SAR value, may have a B1 plus RMS value, or they may cross-list between the two. B1 RMS and SAR, they work on different principles, and so there's not a, can't translate readily back and forth from one to the next. They're sort of independent calculations. So 2 watts per kilogram does not translate to 2 microtesla of B1 plus RMS. And there's not a conversion factor. You really need to look at them as independent values. But if you have a patient with an implant or device, and you have an MR system that gives you both SAR and B1 RMS, you can use whatever the more permissive value is. If the implant or device has has a B1 RMS and a SAR, even if using the B1 RMS value, your MR system tells you that the SAR for that study would be above the allowable SAR on the SAR condition, as long as you comply with one or the other, you'll be fine, according to the way that the MR conditional labeling works. So diffuse heating is a patient comfort issue, but generally speaking, it's not a safety issue. I think that the SED, the lockouts for SED, I think that they're wholly misplaced. I don't think that they're really protecting anybody from anything, from known injuries. To the best of my knowledge, there are no reported injuries globally. I've never seen a single one related to cumulative thermal load for that. So as I mentioned, SAR should really be called ESAR, estimated SAR, because it varies tremendously. Implants totally mess up SAR distribution and SAR predictions. So for implant devices, if you can use B1 RMS, if your system supports it, you may find that more advantageous. And then one last bit about diffuse versus focal heating. So we have a woman who goes swimming in the sea, and the water is very cold, and she gets cold and she gets numb, and so she gets back out on the beach and she sits in the sunshine, right? And she lets the sun hit her and warm her back up. This is diffuse heating, right? We have a fixed source of power, the sun. We have a fixed rate of power distribution, the sunshine. And we have the subject who is receiving that power. General diffuse warming over the entire body. What if I introduce a giant lens and I suspend it above her? Have I changed the power of the sun? No. Have I changed the rate at which the sun is transmitting energy?
No.
Have I changed the total amount of energy that is striking this woman? I haven't changed the total amount of energy. I've focused it. I've taken the energy that was distributed over her entire body, and now I've focused it. I've narrowed that same amount of energy to her leg. What would happen to her? We would burn her, right? How is it that we burn her if I'm giving her the exact same amount of energy?
Because it's focused in one place.
The surface.
Because we've changed the area over which that energy is being deposited. When it comes to radio frequency burns, what we're talking about in one form or another is we're talking about a lens, not a real lens. We're talking about the concept of a lens, the idea that we're going to take energy that is supposed to be generally broadly distributed, and somehow we're narrowing it down into a small area of space and time. For the proximity burns that we talked about, being too close to the transmit element. So the RF power where it transmit is high, right? Because it gets weaker as it radiates out. So the closer we get to the point of transmission, it's higher, it's more focally concentrated. If we have an electrical conductor, an implant, a lead, a wire, something like that, that acts as an antenna, it absorbs that radio frequency energy with much greater facility than normal human tissue. And so what was supposed to be diffused throughout the body all of a sudden becomes concentrated into the pacemaker lead. Within our patients, we have a number of lenses, potentially, in the form of implants and devices that may allow for the focal concentration. It doesn't change the amount of RF power that we're transmitting. All it does is it changes where in the patient's body it collects or deposits. So RF burns are not necessarily an indication that your machine is malfunctioning. The machine is transmitting, in theory, the same amount of power. It's that something about the position of the patient or things that are in the bore with the patient, or the large caliber body loops that the patient forms with their own tissues, that it's these elements that act as lenses, act as opportunities to focus the energy from the radio frequency power and concentrate it. And I think, so we already touched on this. The three primary elements of burns, or primary causes of burns related to radio frequency power, are proximity, resonant circuitry, and large caliber body loops. And with that, we will take 15-minute break or so, 15, 20 minutes.
15 minutes, enough.
To grab something to drink. And we will resume back here.